There's a lot of assumptions and concerns, both on the side of the medical professional and on the side of the patient, that create barriers to this conversation. I mean, certainly discomfort and just feeling uncomfortable bringing it up and talking about it is a huge issue. There are just so many important things to talk about at the oncologist visit, from treatment, chemo, side effects, scans, mood, mental health, so many different things. And sometimes it feels like sexual health concerns may fall to the bottom of the list. And frankly, historically and even ongoing today, focus on sexual health and medical training is really still not where it needs to be.
Hi, everyone. I'm Samira Daswani, the host of the podcast, The Patient from Hell. I have an incredible guest with us today. I have Dr. Laila Agrawal, who I think, if I'm not mistaken, is one of the globally renowned experts in sexual health, specifically for oncology patients. And I have probably the most number of questions I've ever had for any guest on the show. So welcome.
Well, thank you very much. I'm very happy to be here talking to you. I don't know if I'm world renowned or anything like that, but I think this is such an important topic, one that is definitely not addressed nearly enough. And I'm very happy to be here and be able to shine a little light onto what is sometimes considered to be a taboo topic.
Thank you. Okay, we're going to dive right in. Can I start by asking you, what percentage of breast cancer patients, in your experience, deal with sexual health issues?
So sexual health is a really common issue after a breast cancer diagnosis, and estimates will vary, but up to 90% of breast cancer survivors may experience changes in their sexual health.
I didn't know it was 90%. Okay. All right. And then why do oncologists skip this conversation?
I think it's tough. I mean, I think there's a lot of reasons why this is a tricky conversation to have. And I think there's a lot of assumptions and concerns, both on the side of the medical professional and on the side of the patient, that create barriers to this conversation. I mean, certainly discomfort and just feeling uncomfortable bringing it up and talking about it is a huge issue. But on top of it, there are just so many important things to talk about at the oncologist visit, from treatment, chemo, side effects, scans, mood, mental health, so many different things. And sometimes it feels like sexual health concerns may fall to the bottom of the list. And frankly, historically and even ongoing today, focus on sexual health and medical training is really still not where it needs to be. And so a lot of medical professionals may feel like they don't have the tools, and in the community or in their hospital systems, there may not be the resources for some of these referrals or additional evaluation.
Okay, let's maybe start with a couple of myths. What's the biggest misconception you have heard from patients about sex, sexual health, during and then after treatment?
I think there's a lot. And again, I think that a lot of this comes from the taboo nature that these questions don't always get asked a lot. But actually, one question that I get asked frequently is, if I have sex or if I have an orgasm, will that increase my chance of a cancer recurrence? And the answer is no.
Doctor, you will have to expand on that. I'm surprised at that question.
Mhm.
What do you think is underlying what's the question behind the question? Why would a patient
Well,
assume?
I think that some people are concerned that if someone has an orgasm or they have sex, that could change things hormonally, that could contribute to a cancer recurrence. Another question that comes up is whether cancer can be passed on sexually, whether it would be a risk. So that's another question that comes up. And then, certainly, I think some people may think that you can't have sex during treatment, during chemotherapy. And certainly there are times when it is safe to do so after, understanding all the precautions that are needed. So I think the range of these myths, it really is very wide reaching, because if we don't talk about it, how are we really to know what the what the concerns are. And so I think it's really important that you're out here addressing these myths and maybe even learning new myths that you hadn't heard of before.
Oh, I'm going to learn a lot. I can tell already.
Mhm.
Okay, so let's maybe start with one thing you tell any newly diagnosed patient about sexual.
One thing that I always try to talk about is that cancer diagnosis and treatment can impact somebody's sexual health. And there's many different ways that this could occur depending on what the treatment is, what the cancer is, and what is going on. But I think preparing somebody for the possibility of a change to occur is important.
We're going to switch to chapter number 2, which is a laundry list of symptoms that I think fall into the general bucket of sexual health. Symptoms, side effects, feelings, a bunch of them. We'll just go one by one. I'd love for you to talk about them. And then if I miss anything that feels very important for you, I would love to invite you to add to that list.
Sure.
Okay, the first one. When a patient says, I have no libido, what is happening?
Yeah, so this is a really common one. In fact, we recently did a survey about breast cancer survivors and what were their concerns about sexual health. And low libido or low sexual desire was actually the most common concern. So this is super common. We see this all the time. And so, I kind of think about this in two different ways. So, first of all, there could be a physical symptom like pain. A lot of cancer treatments, including endocrine therapy like hormone blocking or lowering treatments or chemotherapy or other things, can cause physical symptoms, including vaginal dryness, decreased lubrication, or other reasons to have pain with intercourse. And if something is painful, if sex is painful, then that's certainly going to decrease the desire to have sex. So whenever somebody says that, I always want to follow that up with more questions about exactly what is going on. Is this low desire secondary to pain or a physical symptom, or is there maybe no pain, but just a complete kind of lack of sexual desire or interest in having sex? And so sexual response is really the way that we think of arousal and desire and orgasm. And there's actually theories and models around sexuality and how this works. And I think a lot of people, I would say this might be another myth in our society, is that the way sexuality works is that somebody has a spontaneous sex drive or spontaneous desire that leads to arousal and then having sex and having an orgasm. But in reality, the current model of this is a little bit different, and it allows for both this spontaneous desire as well as something called a reactive or responsive. And so, what that means is something else may occur first, like desire for emotional intimacy or physical arousal or mental arousal, or something else may trigger that sexual response cycle. And then as a result, somebody may experience responsive desire. And I think this is really, really key to understand. And when I talk to my own patients about this, sometimes it really resonates. Like, yes, I don't have that spontaneous feeling anymore, but if I'm with my partner, I can still feel desire, in a responsive way. And that's helpful because it doesn't mean that desire is gone. It means that a person can work with this responsive desire.
That is incredible. Okay, I had thought of it that way, and that makes so much sense to me. My question here for you is, if we just stick with that mental model, do you think that is true for both patients during treatment and then post?
Absolutely. And it's also true even if for people who don't have cancer, that this is just a natural form of desire, that desire will change throughout somebody's lifespan, throughout the course of a relationship, with age. I mean, many different things can factor into this. And this is just a normal expression of human sexuality.
You mentioned this already, vaginal dryness. Can we talk about that? Because that is probably the most common thing that I hear in the survivor community,
Mhm.
especially if you are on long term maintenance treatment for hormone therapy or something similar. What is it? Why does it happen? And then what's the range? Little dryness all the way to feeling like sandpaper?
Absolutely. Yes. So vaginal dryness is something that can happen when hormones shift. And so, with the lowering of hormones, like when estrogen either decreases through natural menopause, or if somebody is premenopausal and they have chemo, that could result in a earlier menopause. And then, as you mentioned, a lot of people who have a hormone sensitive breast cancer are on endocrine therapy treatments to either block or lower their hormones. And this could include tamoxifen or aromatase inhibitors, or sometimes even medicines to suppress ovarian function. And also, people can have their ovaries removed that can result in menopause. And so, there's something that is termed the genitourinary syndrome of menopause. And that basically is a constellation of not only vaginal dryness, but multiple things that happen that are the result of the changes of the hormones, including dryness, decreased lubrication, but also thinning of the tissue, reduced blood flow, and also there can be reduced elasticity or stretchiness, or even shortening of the vagina. The pelvic floor can be impacted, urinary symptoms like urgency or even incontinence. So, all of these things are part of this genitourinary syndrome of menopause. And really, that feeling of dryness, discomfort, irritation, itching, or burning, this is a really common thing that we see. And one that I really think we should be doing a better job of counseling people up front, that yes, this is something that is a common side effect of, your medication you're going to be going on. And here's what to do to prepare for it. So one of the things I often will talk about are these non-hormonal vaginal moisturizers. So they're for the vulva and the vagina. And they come in a bunch of different forms like gels or creams or inserts. And they're meant to be used on a regular basis to provide moisture back to the tissue. Just like I kind of compare it, if it's wintertime and your, hands are dry, you have to moisturize on a regular basis. And so this is something that I counsel my patients at least 3 times a week, sometimes even more. This is just another step in the skincare routine now. So these are over the counter products. And some of them contain an additional ingredient, which is called hyaluronic acid. And you'll see that in, face creams and serums too, because it is an ingredient that pulls in more moisture. And so they can be even more effective than a plain moisturizer. So there are multiple products available, vulvovaginal moisturizers with hyaluronic acid, that can be used on a regular basis for that symptom of dryness.
Uh, Home remedies, coconut oil, anything like that?
Yeah. So there's probably a little controversy. Different people might have different opinions about using things like natural oils, coconut oil, things like that. So I always would encourage somebody to talk to their own medical team about that. But many of my patients use coconut oil as a vulvar and vaginal moisturizer and find that it helps them. So, I mean, I don't have any concern with that personally.
Okay. And then what about the other controversial one, which is hormonal treatments for like local hormonal treatments for vaginal dryness?
Yeah. So, really, a low dose vaginal hormone, like a low dose vaginal estrogen, is really the best treatment for these symptoms of genitourinary syndrome of menopause. And these are going to be the first line treatment for the majority of women who have this concern. And so, a low dose vaginal hormone, again, can come in different forms, like a cream, a insert into the vagina, or a suppository, and even a ring, a long lasting ring that can be inserted into the vagina for 3 months at a time. So there's different formulations and even different types of hormones that are standard for this symptom. But for people who have a hormone sensitive breast cancer, of course, there is additional thought that would go into the use of a low dose vaginal hormone, especially in the setting of using endocrine therapy or so forth. But really, this is truly what is in the category of a shared decision between an informed patient and her medical team regarding use of these vaginal hormones, even with hormone positive breast cancer, even while on endocrine therapy, including with an aromatase inhibitor. So, the reason I say that is because multiple medical societies have actually tackled this exact question. And this ranges from ASCO, which is one of the major oncology societies, the GYN societies, women's sexual health, and menopause societies. And they all put the use of vaginal hormones in individuals with breast cancer into the category of, yes, you can talk about this in the context of shared decision making. So I think that could also be another misconception that somebody might think, oh, because I had breast cancer that was hormone receptor positive, I can't use this. And that's just not true. That's not supported by the guidelines. Multiple of these guidelines are saying, yes, using discussion, talking about risks and benefits with shared decision making, these are absolutely options. And I certainly have many of my own patients who are on aromatase inhibitors, who are on tamoxifen, on vaginal hormones after talking about the risks and benefits.
Dr. Agrawal, do you see any differences in the world of, I can't pronounce the word,
The genitourinary syndrome of menopause.
yes, for women where they're already postmenopausal and they get diagnosed, and then for women who are premenopausal at diagnosis, but in order to be on an aromatase inhibitor, they're given an ovarian suppressor or they're put into chemically induced menopause, or like whatever we call it from a clinical perspective. Any differences there?
Well, certainly both scenarios, if you have someone who's premenopausal, who's younger, and then goes on ovarian function suppression, that scenario is going to be a much more profound change in the hormones, like a rapid and profound drop in the hormones. And so sometimes those symptoms are more severe. And not only the genitourinary symptoms, a little out of the scope of today's discussion, but also the general menopausal symptoms that come with it. But on the other hand, someone who is postmenopausal may have already been experiencing those symptoms even before going on an aromatase inhibitor. And so they might have had a longer duration that then worsens. And these are things that don't get better on their own. In fact, they can get, worse over time. And so, we see it in both situations for sure.
That is very helpful. Okay. I'm going to actually, before I switch, any other symptom that you see commonly in your clinic that you would like to address?
Yes. So another symptom that we see commonly relates to pain with penetrative intercourse. And we've talked about dryness, but not all pain is going to be coming from dryness. And there is another issue that can occur, which is a pelvic floor muscle dysfunction. So the pelvic floor muscles, they support the pelvis and the organs of the pelvis. They need to be able to work together in a coordinated way. And sometimes that gets disturbed. And what results is what we call dysfunction, not working together in the correct way. And as a result, different things can happen. If there's weakening in the muscle, sometimes we see things like organ prolapse. But what I often see as it relates to sexual concerns is a hyperactive pelvic floor, meaning that those muscles are either too activated and someone might experience pain with vaginal penetration. And so for that, anybody who's having pain should have a proper pelvic exam or gynecological exam to make sure that they're diagnosed properly. But if it is pelvic floor dysfunction, then I refer to a specialized pelvic physical therapist, and they have a lot of different options at their disposal to help treat this muscle dysfunction. Just like if you had, a shoulder pain or a back pain, you would go see a physical therapist. These are focused on these internal muscles. And I have certainly had many patients who had, even pretty severe symptoms like pain, could not have penetrative intercourse, able to work with a physical therapist and improve and have resolution of this symptom. So it's important to note not all pain is due to dryness, and that this internal pain needs a physical exam, but may be due to pelvic floor dysfunction.
Dr. Agrawal, if I'm a patient and my center doesn't have someone who is a specialist in even sexual health and as it pertains to oncology, what should I do? Who should I call? How do I get help if where I'm getting treated, maybe a community site may not have the width of specialties? What would you recommend?
So I would say the first step would be to talk to the different people on your medical team to see if they know anybody who is a specialist, because I've certainly heard of people who might have even had the resource there in their hospital system or in their community, but they just didn't know about it. So even if the first person that you ask doesn't know about it, I really encourage kind of asking multiple different people on your team. And that might include your gynecologist or primary care, as well as oncologists. And then some of these professional societies that are specialized in the treatment of sexual health will have provider directories available online. And so I can provide you those resources. But for example, for a medical provider or a sex therapist or physical therapist, this way people can locate professionals in their geographic area.
Thank you. Okay, next chapter. Ready? I'm going to go into the area of body image and emotional intimacy. Okay, so the first one is, how does losing a breast impact how a woman might feel about their sexuality?
So when people are diagnosed with breast cancer, one of the treatments is mastectomy or removal of the breast. And after that, there's options to either do breast reconstruction, which there are different ways to do that, or some people either choose or are not eligible for breast reconstruction. And so, this is a pretty major change in the body, and it can result in different types of feelings. For example, number one, after mastectomy, often the sensation is gone. So the feeling over the breast, and even if it's a nipple sparing procedure, the feeling of the nipple may not be there. There are actually kind of newer pioneering techniques to do nerve sparing surgeries, but those are not, options for everybody, certainly. And so when sensation is gone, that can really change not only the feelings like arousal that might come from breast sensation, but also can really change how somebody feels in their own body. Some of the treatments or some of the methods of breast reconstruction involve implant. And I think it's important to just understand, how does an individual feel about their body now. So this is really does not have anything to do with necessarily the appearance of it. It has more to do with how somebody feels about their body and how that relates to their thoughts, their behaviors, their emotion, and relates to their sexuality as well.
And then what is the difference between body image issues and the loss of sexual desire?
Body image and loss of desire are separate things, but they might be intersecting. So somebody may have a change in their body image, but not experience loss of sexual desire, vice versa, or they could be really interrelated. And I think it also comes to communication with the partner as well, because certainly there can be fears, concerns, hesitations, and assumptions about the body, the reconstruction, and what the partner thinks. And I think this is a really sensitive area, and one where open communication can be difficult, but is essential really to understanding what both partners are feeling about this.
Um, when should someone consider seeing a sex therapist versus going to your medical provider?
So, a sex therapist is a mental health professional who has extra expertise in discussing issues related to sexuality. So, this is really a, talking situation. And I find that they are extremely helpful in certainly issues related to desire, working with couples and communication and body image, and many other things as well. So, if the issue is related to a physical problem, like we talked about, pain or dryness or things like that, talking with a medical provider would be the first step. And oftentimes, the medical provider can then refer or recommend a sex therapist. Um, because really, when we talk about sexuality, I don't think I've even used this term yet today, which is shocking, but this is really what we call a biopsychosocial model. That means that physical, mental, emotional, and social things are really interwoven in somebody's experience. So I would say most of the time, we don't just find like one isolated thing, that many things are actually interwoven. So I really think of these as both extremely helpful resources, medical and sex therapist or psychosocial counselor or psychologist, and really, what these different specialists can offer will really complement.
Okay. You alluded to this in one of your previous answers, which is the partner conversation becomes kind of part and parcel of the experience of dealing with this sort of syndrome of things we're talking about. My first question for you is how often does that come up in the clinic itself? Like, how often are you telling a patient, hey, this might be a conversation for you and your partner? We should have your partner come into this conversation. So that's question one. And then the second thing is, what have you seen is the impact on intimate relationships as a consequence of dealing with cancer?
Yeah, so that's a big question. So lots of different components there. So number one, talking about sex, the probably the ideal way to do this would be first to have this discussion um, privately or with the partner, whatever the patient prefers. Some people may feel more comfortable privately, other people might feel more comfortable with their partner there. So they're both, perfectly valid ways to go about it. And in fact, some people might have talked to their partner about it ahead of time, and their partner is actually their support to help them bring it up and have these concerns addressed. But if you want to talk about it privately, I think just, ask your partner to step out for a moment, or, tell the medical team that you want to talk privately, and then they can discreetly ask them to step out. But I think it's also an important conversation to have together because unless we talk about it, the partner may not understand that all these changes are a result of medical treatment, and they may not understand what is safe, what is not safe, what are the options, what can I be doing to support my partner who's going through this. So I really think that involving the partner in these conversations is important, but it should be done in the way that the patient feels most comfortable about it. So a lot of times when I have visits about sexual health, sometimes someone will come by themselves, and other times they'll bring their partner, and it's entirely up to them.
How have you found you can help the patient explain to that partner some version of like, I love you, I care about you, but I don't want sex?
So I think that's something that a lot of people struggle with. And I think, talking about it in terms of these are the side effects of the treatment, and this is how it's impacted me. And, I think one concept is that if there is any form of touch or connection that people might be afraid if they have a low desire or they don't want to have sex, that any type of connection or touch will then lead to their partner wanting sex. And so sometimes what I see is people are even pulling away from simple touch because they don't want the next step to happen, whether that is going to be kissing or touching or sex. And they feel like once we've gone to step one, we're on an automatic, route here. And so one thing that I talk about with my patients is that with open communication with the partner, you can say, I don't feel ready for sex or comfortable for sex, but I still want to enjoy touch. So, you can kind of take certain activities off the table, but still say, I would still enjoy to do, X, Y, and Z. And one way to think about this is just everyday affection or everyday connection. And I think it's important to talk to the partner, not in the moment, but ahead of time and say, I still want to have this form of connection, but I don't feel ready or I don't want to have these other activities. And I think that can be a way to open communication to explain where someone is um, feeling mentally and physically and to continue that connection and support.
What about single women who are dating during treatment or after treatment?
Yeah. So I think all of the things we've talked about regarding sexual health really are applicable whether or not somebody currently has a partner or does or doesn't wish to have a partner in the future, because a lot of these things are not only about sexual health, they're about general health. Sexual health is a part of general health. And so all the stuff we've talked about, vaginal health, vulvar health, pelvic floor health, these are going to have impacts reaching far beyond sex. urinary function, even to the point of certain activities or certain clothes or doing certain things is uncomfortable, urinary tract infections, other types of pain. And so, first of all, I would say, regardless of anybody's wish to have sex or not in the future, it's important to pay attention to pelvic and genital health in general. And number two, you were asking about people dating. And so, um, I think even if somebody isn't dating, but they hope to be in the future, it's important to think about all of these issues because sometimes if too much time passes, things could, worsen, like dryness without paying attention to that, or pelvic floor dysfunction is not just going to get better on its own. So it's important to know if there's any issues going on and to address them. And then I think it's going to be really individual when people are dating. They are going to be thinking about, do I tell a potential date that I have had a diagnosis of cancer, that I have had these treatments or maybe surgeries? And that's going to be really individual about somebody's comfort and what they want to do.
Let's maybe talk about orgasm. How does treatment affect the ability to orgasm?
So, changes in orgasm are one of the things that can occur. And again, orgasm is just like biopsychosocial. There's so many different things that can go into that, including all the things we've talked about, pain and, breast or nipple sensation or other things like that. And so, first I would always address these underlying issues. But there are also ways, and a sex therapist can help with this. There's other techniques where people may feel like the same things that worked before don't work anymore. And that can lead to a lot of feeling of frustration. And when that frustration kicks in, then that really dampens the experience or, the process towards having an orgasm. So, one thing that can be done is switching the idea away from a goal oriented, like if there's not an orgasm, this was a failure, to an experience of connection and pleasure. And so, that's just sort of a mindset shift, but it can sort of get people a little bit out of this path of frustration and feeling like things didn't work or they weren't successful to working towards, this is an experience that is meant to connect us emotionally and to be pleasurable, and that can be enjoyable. So I think there's a lot to it. This is not a simple question. And also, just taking a step back, and if the body feels different or things feel different, to sort of just with an open mind re-examine pleasure, like what feels good, what doesn't feel good. And there's different ways to do that, of course.
If we think about reclaiming sexuality as a concept, so you have, I'm oversimplifying this, but you get diagnosed, very rough, blinders on, you're kind of tunnel vision, getting to a treatment plan, you go through treatment. You might be in treatment for a long time if you're metastatic. Early stage settings in breast cancer, hormone positive, you're active treatment, a couple of months, maybe a year. And then you have this long tail on an aromatase inhibitor or a hormone therapy, anything between a couple of years to like 10 years. Does the sexual health recovery timeline depend a little bit on the treatment plan you're on?
I would say everybody's experience is going to be different, but what I would say is not to expect for things to just get better on their own without addressing them. So that's why I always say it's very important to address these issues because they're not necessarily going to resolve. And we've seen from studies that these sexual health concerns can persist. And that's why I believe it's so important to be talking about it from the get go. And, when somebody's ready to start addressing these concerns, to do it earlier rather than later. And everyone's going to feel a little different about when they might want to do different things. However, I would say the physical symptoms are important to be addressing from the beginning.
And then what do you tell a patient who feels guilty for wanting to have sex during and after cancer?
I think that's really complex because there's probably a lot that goes into it, but it is a normal thing to desire to have sex, and it is normal to not desire to have sex. So both are fine. And, I think that's something that people are going to feel different about, but there's no reason to feel guilty about that.
Dr. Well, I think we're almost done. I have a bunch of rapid fire mythbuster questions for you. But before we go there, is there any topic that you wanted to cover that we haven't covered?
I think you've hit on really big, important topics. So let's hear the rapid fire.
All right. I have 4, maybe 5 for you. First one, does sugar feed cancer of the libido?
Does sugar feed cancer of the libido?
Or
Oh,
sorry.
sorry.
No, that was me missing
Um,
it.
so sugar does not feed cancer. We always encourage a healthy lifestyle and a healthy nutrition, which doesn't include like super high sugar. But it's fine for people to have dessert now and then. Absolutely. Enjoy it.
All right, next one. Do I need to use a condom during chemo?
So, this is something that everybody needs to discuss with their medical professional team. But oftentimes, it is recommended to use a barrier contraceptive method like a condom in the period after chemotherapy to avoid direct contact with certain bodily fluids. Also, if someone can become pregnant, it's important to have a really solid method of pregnancy prevention during chemotherapy.
Will vaginal estrogen cause a cancer recurrence?
So, vaginal estrogen does not cause breast cancer to form in the first place. And somebody who's had breast cancer and is considering using vaginal estrogen needs to have this individual discussion with their medical team.
Can you have sex with a port?
So, having a port is not a contraindication to having sex. Absolutely.
Okay. My last question for you is, how does someone find out more? Like, what are the resources you'd recommend if I want to learn more about this topic?
So, resources, and we can put some in your notes, but American Cancer Society has information online. Breastcancer.org has great information about sexual health as well. And then, I mentioned ASCO has information as well about sex after cancer. So there are lots of reliable resources out there.
Thank you so much for joining us today. Thank you for sharing your wisdom. I have a feeling that a lot of patients are going to really benefit from listening to this episode. So I appreciate you taking the time.
Thank you so much for having me and for all the work you do to get information to patients.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors.